my lectures about intraoperative neuromonitoring, physiology and application. It's an observation of neurological function during surgery, which can divide it into two techniques, which mapping and monitoring. Mapping, we identify the anatomical neurostructures, which allow the surgeon to do the surgery without causing any harm to other vital structure and improve the post-operative outcome. While monitoring is continuously evaluates the functional integrity. So in any immediate feedback that we have about warning sign abnormalities, we can proceed it with immediate intervention. Then this does provide improve post-operative neurological outcome. So in the studies, they shows 50 years in neurosurgical studies, they shows two major innovation that change, that evaluate, that evolve neurosurgeon to do a lot more in their practice. One is an image guidance device, and the one intraoperative neuromonitoring. Therefore, this shows that the importance of IOM in delivering and maximize patient safety during operation and improve patient outcome. Okay, before I proceed more, this is evoke potential, one of the response that we recorded during IOM. As we can see, evoke potential can be stimulated by electrical or magnetic, and usually we observe either motor or sensory. This is its SCP response. There is two things that we look upon. First is latency. Latency is meant by how fast the response after stimulation. Alright, and then amplitude is about how strong is the response after stimulation. Strength is calculated from peak to trough. Right, so there is the peak can be either positive, which is P, or negative, and followed by latency in millisecond. P40 and P20 mean that the point that we recorded, which is of our special interest to know about it, after 40 millisecond or 20 millisecond after stimulus been given. Usually this is a normal point. So if any point is above it, it consider prolonged latency. Alright, so there is also a red waveform that you can see here. This is the baseline that we took. Then there is a green waveform, is an average that they took throughout the surgery, and the white waveform, this is the current SSP that we are monitoring. Okay, this generally speaking, there's two things that consider a warning sign. Is either amplitude reduction more than 50% or increased latency more than 10%. This should be alert us, and we need to do the necessary to intervene it before permanent damage happen. Okay, this is when we do a IOM, we need a response. So the response can be either you have a free running without any spontaneous, which is EMG and EG, while evoke is why you give some illicit stimulate to record the response, what we call evoke potential. It can be divided into motor, which is ascending pathway, and sensory, which is descending pathway. Okay. Ascending pathway is sensory, descending pathway is the motor. So motor is EMG and stimulating EMG and motor evoke potential, while sensory you can have a peripheral nerve monitoring, auditory monitoring, and visual evoke potential. So we go first for motor evoke potential. Is one of the essential things that we need now in our spines and even neurosurgery. Okay, it's a monitor the integrity of descending tract. Okay, why we stimulate by transcranial electrical stimuli or by transmagnetic stimuli. However, transmagnetic stimuli we do only in awake patient, because the signal diminish after patient under anesthesia. Alright, so another one is we directly give stimulus to the brain itself. Okay, mainly for mapping of the corticals. Okay, so it's recorded at two sites mainly. First, the effector muscle, where we monitor the compound muscle action potential, while we can put some catheter inside epidural or intratracheal space, where we monitor the direct D or indirect wave. Okay, so usually nowadays we use the SACP with MEP with SACP plus minus the EMG to see the spinal cord function, to see the anterior and posterior circulation, to complete the monitoring of assessment real time of the patient neurology during surgery. Okay, this is where we stimulate, we put a needle at the site. This according to international 10 to 20% system, whereby they attach to the interested area that they want to see. And after that, they record at the M abductor pollicis brevis, M abductor digital minimi, and the rest to see the stimulation the response that happened after the stimulation. So the warning sign that we must be alert if the totally absent of MP, it should jump up and find out the causes. And compared to SSP, the decrease of 50%. However, for MEP, the decrease should be more than 70% amplitude from the baseline. And there is a possibility if the increased latency or the threshold stimulation become increased, so we must suspect there is a possibility that the area are damaging, either from mechanical, thermal, physiology, or surgical itself. And some people said return of MEP post-intervention is expected with good outcome, which is very good. So we can see the changes that happen during interop that impact the post-operative outcome. However, the limitation is not continuous. We need to stimulate, then we can see the response. So it's used in spine surgery because the dynamic changes in surgery, like pedicle screw incision, they retract. So at a certain point of interest, they will do MEP to see the response and to evaluate the neurological status at that time. So anesthetic influence is very sensitive to volatile agent and muscle reaction due to the physiology that happens. Okay, and side effect are tongue laceration, and we have to put a tongue bite to avoid tongue laceration due to the masseter jaw stimulation that happen. And it have a relative contraindication in patient, epilepsy, pacemaker, vascular, clip, and so on. This is a patient who are going for spine surgery, and they put one of the things that monitor motor evoked potential. When the surgeon do the distraction and started to put a nailing of the screw, there is a drop in MEP more than 50%. At that time, we informed the surgeon, alerted, and he still proceeded, and they screw further. However, MEP amplitude become more than 70% reduction. So the surgeon was noted, and he stopped, and he changed direction of the screw. So after that, the MEP increased back, as you see, to normal amplitude, and operation finished and closed, and patient have no deficit. That's how MEP that been observed in spine surgery. However, usually weakness is neuromuscular blockade. Usually when we apply neuromuscular blockade, it can act at a neuromuscular junction, is prevent the MEP recording and establish. However, in certain area, we can give what we call partial neuromuscular blockade by giving some infusion of muscle relaxant. It may use in patient whereby the response that have so aggressive that is disturb the surgical site, or there is a surgery that required too much manipulation at area that attached to a muscle very strongly, so they can't do the operation without that. And if the interference so much, sometimes they use it to improve. So you basically is upon the surgeon's decision to make, and it should be discussed prior to the surgery. So how we monitor whether the reading MEP is available or not, because when you start to give partial neuromuscular, the amplitude of MEP will be dropped compared to the baseline. So what they do a single twitch evoke electromyography. So they keep T1 at 5 to 50%. So any MEP reading at that point of time, they accept. Or you can use also TOF count, whereby they go to 2 or 4, and it's acceptable MEP recording at the time. So they will stimulate necessary if the amplitude more decreasing. Okay, how about D-wave? D-wave is very robust. It's different from compound muscle action potential. So it doesn't affect to any anesthesia. So usually we rarely use it unless in certain cases, such as used in intradural extramedullary tumor, because one is invasive. You have to put the catheter down below in the intratracheal to epidural caudally to assess the function of D-wave, and sometimes you have to put upwards cephalic to be as a control. Okay, so usually it used also with motor evoked potential, whereby it predict motor outcome. For example, if the decrease is more than 50% baseline of D-wave, warning criteria for permanent motor deficit, which is most likely patient will have permanent motor deficit if they assess the tumor more. So the surgeon need to be rethink whether is benefit or not for the patient. So sometimes they stop the surgery. So if the MEP absent, however the D-wave preserve the amplitude more than 50%, it reflects a transient of deficit in affected limb. So therefore patient have possible high whereby he is recover from the deficit loss after operation. Okay, so the surgeon will decide, okay, we can continue surgery if the benefit to cut the tumor totally excised. So it depends on the benefit and harm. So the DWAVE serve the purpose at this point of time. Okay, now we talk about somatosensory is opposite from motor evoked potential, whereby it's monitoring of the dorsum column integrity, whereby we stimulate the nerve, we monitor what happened in the cortex and the pathway from it, from the spine, from the cervical junction and up to the cortex. We stimulate at median nerve, usually for monitoring upper extremities, and at the posterior nerve to monitoring the lower extremities, and we record the SAP at the cranial area or at the point of interest according to 1020 International System Standard. Okay, so it can be recorded from up points or popliteal fossa. It depends on the muscle that we monitor, median or tibialis anterior. Then we monitor at the point of spine, brainstem, primary cortical, somatosensory area. As I mentioned you before, you can see the point of interest they put already and N22. This is the point of interest they want to see if there is any deficit along the junction from the periphery up to the brain. Okay, the advantage of it is easy to implement. You just put the needle, it doesn't cause any tongue laceration or what, and it's readily available on the market, and a good basic indicator of cord function during position change, where we can see from supine that they change to the prone, so that any brachius plexus injury or any that it can detect. However, limitation is a bit delay response, 5 to 30 minutes. So if there is a delay, we should intervene it earlier. There is no detail on motor, which is anterior part. That's why we use with MEP during spine surgery. Latency is easily affected by physiology changes, hypotension, hypothermia, and for the volatile is as dose dependent. So usually we kept max possible less than 0.5. Even 0.5, it can also disturb the latency, even the amplitude. So we have to be careful. So for auditory evoked potential is whereby we want to see the auditory system monitoring, okay, for CT angle tumor and other operation. So what we do, we put some sort of microphone in the patient, then we deliver a click sound. So it generate, it give stimulation at the time. It generate 5 waves that have our interest. This 5 waves indicate the site of interest that possibly have damage, or we want to avoid damage at the point of time. Okay, 1, 2, 3 is auditory nerve, 3 at medulla, and 4 and 5 at lemniscus lateralis. So the alarm criteria, we must be alert, see the shape, prolonged latency more than 1 millisecond, decreased amplitude, and if there is a permanent loss of wave V, there will be significant post-operating hearing loss. Okay, this is rarely we do in our practice, what we call visual evoked potential. This is my patient who going for operation of occipital with his complaint is visual impairment. So they need to monitor visual because the tumor at the, mostly at the side that if they cutting, there will be loss of visual totally. So is what they use it as a special goggles that generating some LED infralight, okay, to stimulate, and the response will be at the cortex. However, rarely we use because the VAP is the most sensitive to any anesthesia, either inhalational or intravenous. Okay, then we go to EMG. Is the basic that we usually use in thyroid mapping and etc. Okay, it's a recording of electrical activity of the muscle. We stimulate the peripheral motor nerve and it cause muscle contraction, and we record it. So we can record at cranial nerve, we can record at recurrent laryngeal nerve, and peripheral or spinal side. Usually there is a 3 type of technique that we do: free running, which is spontaneous; stimulating imaging, we deliver, then we see the response; and intraoperative nerve conduction study. Okay, this is the first one is spontaneous free running EMG. As you can see, if spontaneous, if there is no response, it should be silent, meaning that you won't see any spike or burst. So if you see spike or burst, there is a sign that the nerve been impaired by either mechanical, thermal, or ischemia. So in this case, as you see at A axis, there is a continuous persistent spiking, showing there is a possibility, highly possibility of permanent damage. So the surgeon must be noted and probably have to avoid the necessary area. And we use in motor mapping, whereby we put a probe, we stimulate, and we see the stimulation either visually, either like patient audially. It's usually been sometimes we do in awake patient, where we assess the speech, we assess their motor, and we see the changes of the wave or even sounds. So we map and we avoid the necessary important things area before proceeded with surgery. And this is a stimulating energy also we use in pedicle screw. As you can see on the right side, the pedicle screw was overshoot, the replacement. So when the stimulating is only needed a low energy, which is 9. So the surgeon will be alerted and he will remove and redirected the pedicle screw. As you can see over the left side, the pedicle screw was put in the good position, it's not crossing the midline. And when they do a EMG stimulating, the EMG stimulating require high power, meaning that is far from away the side that can injure the nerve. Okay, so we go for effect of anesthesia agent to evoke potential. Volatile agent it will definitely increase latency amplitude. So the effect usually at 0.3 to 0.5. Usually we advise for SSP try to use at less than 0.5. Right? And isoflurane is more than SIBO and desflurane. Nitroxide is a bit controversial, but try to avoid it. Propofol is increased, is dose dependent. So if there is impairment, sometimes we reduce the drugs to improve the reading. Thiopentone, barbiturate, need to avoid it. Opioids is no issue for patient, and usually we use remifentanil with combination to propofol to reduce the propofol usage and improve the signal. Other drug that we can enhance reading or signal are the ketamine, etomidate and dexmedetomidine, due to the mechanism of action. For muscle relaxation is no for motor evoke potential if possible, unless there is indication. Even if there is indication, we only try to use it normal patient rather than patient who have neuromuscular problem in the beginning. And we need to monitor the T1 and keep it at 5 to 20%, or keep at 3 or 4 at 2 or 2 or 4 twitch. This is summarized. You can see all the drugs that we use in our practice, and the response influence is on evoke potential. As we can see, the amplitude change parallel as the latency change. So the most variable, as I mentioned before, is visual evoke potential, followed by motor evoke potential, then SSCP and brain auditory. Brain auditory is very resistant, so it can use in either way, either inhalational or volatile agent. And dextromethylidine, opioid has no effect. Ketamine and etomidate increase evoke response. Dextromethylidine improve signal because when you apply dextromethylidine in your TIVA, is reducing both your propofol and remifentanil, which improve the signal, because the signal is dose dependent on propofol. This other thing that we have to remind, if there is impaired reading, we need to see the physiological change that can happen that can impact the evoke potential, such as hypotension, hypothermia, increased ICP, hypocarbia can reduce the amplitude, and temperature and hypoglycemia. So if our anesthesia is not a problem, then we check all our surrounding, the physiological changes that can impact the patient. So now, how does we approach for modalities that apply? So usually we do a multi-modal approach. I mean that we use SSP combination with MEP, we use EMG. However, if you use single, meaning that in group 1 is a cortical SSP and cortical AP, we can use sevoflurane but at lower dose. Desflurane or SIBO compared to isoflurane, and we can give muscle relaxant, even it improve the quality of evoke potential. However, in group 2, we can see the D wave, which is resistant to anesthesia, and brain evoke potential. So you can use both volatile IV agents, safe to use even for muscle relaxant. For group 3, when we use only transcranial motor evoked potential, we have to avoid muscle relaxant and volatile. If indeed to use muscle relaxant, we keep as necessary T1 at 10 to 20% baseline, or train of 4 at 2 or 4, right? And we need to titrate our T1 carefully because it's dose dependent. And if we go to group 4, whereby we do a stimulating EMG, okay, spinal motor evoked potential, we have to avoid, if possible, avoid volatile because it has a dose-dependent increment also, and avoid neuromuscular blockade because we want to see the response of the compound muscle action potential also. Okay, this is what I said before. If when the neuromotorist inform the surgeon that there is an impairment, so we as an anesthesia have to see. First, we see is anesthesia too deep, so we adjust our drugs. We see our cerebral function monitoring whether a patient is too deep or not. Then we lighten the anesthesia as necessary. And if there is no about that, we go to the changes, physiological changes that happen: hypothermia, hypotension, anemia, and so on. So if there is, we correct the necessary thing. But if no, we decide to change our technique. Whether we use change TIVA. If we use initially we change to TIVA, we consider enhanced drug that improve signals such as dextroaminidine, ketamine, and we consider changing to intermediate to improve the signal. What we call rebalance the anesthesia. However, if fail, we go to the conservative method, old time, last time, what we call wake-up test or barbarian test for the patient, where we wake up the patient in the middle operation to see whether there is a neurological compromise. Okay, this is I found one of the practice in America. One of the university in America, when there is a problem occurs, mean that the response, the signal not improving or not improving during surgery, they have checklist for the response. So this involve the anesthesia, the technical, the neuromotorist, and the surgeon. So they will take every action that they be taken, and so they won't miss anything to as a documentation. And apart from that, for the patient safety, to maximize the patient safety for the operation. So how do we apply this intraoperative monitoring? We do in cerebral tumor surgery. We do a direct evoke stimulation for neurophysiological testing. Sometimes under anesthesia we use motor, and if you do awake craniotomy, sometimes our interest in the language we do in awake patient. Brainstem surgery is a must to use SSP, MEP, and brain auditory evoked potential because the approach surgery is directly to the area of interest, and brainstem is vital structures, a lot of nerve coming from there, so there is a need to monitor. Cranial nerve monitoring, we can do free running or stimulating EMG. Vascular surgery, sometimes we use in either cerebral vascular or AAA, because we can detect in electrophysiological changes due to the changing of blood pressure causing hypoperfusion. We monitor EAG, EMG, EMEP, SSP, so the surgeon can decide whether he can put a selective shunt to improve the circulation, and it predict risk of post-operative neurological deficit. For spine surgery, both Academy of Neurology and Neurophysiology recommended IOM as effective means of predicting an increased risk of adverse outcome. By evidence they got is level A, and sometimes they record a multi-muscle recording at different sites because it's improved their accuracy, because certain muscle have higher specific and certain muscle have higher sensitivity, so improve higher accuracy and improve post-operative neurological outcome for the patient. And sometimes when even they monitor lower limb area, they will put they will monitor one part of muscle over the upper limb because it acts as a control. When the lower limb got problem and they check the control is okay, so most likely the lesion from the lower limb. However, if both are not okay, so it goes to the systemic causes. And for pediatric, they do EMG stimulating for release of tether cord. They see the sound or the wave, so they can avoid necessary nerve that during the surgery to avoid any neurological damage. For thyroid, parathyroid, esophagus surgery, we see lots. They use EMG stimulating. They want to avoid recurrent laryngeal nerve by stimulating it and detect it. So recent RCT shows it's reduced significantly post-operative recurrent laryngeal nerve. And nowadays we use endotracheal tube-based surface electrode. Compared to last time, they put needle at the area of vocal cord which is left, causing damage and a more reliable reading. Peripheral nerve also we monitor by using direct evoked signal SCCP MEP, and it's reduced actually post nerve damage, especially tumor related and or brachial plexus surgery. So the conclusion, home technician, actually last time surgeon do operation are based on anatomy. Now as time changes, they include more physiology changes. So anatomy and physiology evolve the patient, the surgery, and leads to more defenseless surgery with maximize the patient safety. IOM now is considered indispensable and has become standard practice of most majority of surgery. And we have to take noted anesthesia approach need to be catered to the IOM mentalities, because certain modalities have certain weakness towards the anesthesia that we use. With that, I conclude my lectures and thank you very much.